The healthcare needs of Americans are often complex. To better support patients and their families through an acute or chronic illness, hospitals and health systems are implementing interdisciplinary team-based care to address the scope of patients' medical and social needs across the care continuum. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. In this Members in Action podcast, Julia Resnick, senior program manager at the AHA, is speaking with leaders from CHI Health's Creighton University Medical Center. Doctors Amy McGaha, Tom Gluck, and Kristy Keefner discuss how the use of interdisciplinary care teams enable them to improve value for their patients. And now, to Julia.
Hi, I'm Julia Resnick from the American Hospital Association. Today's podcast is part of the Members in Action series from the Value Initiative. We are highlighting how hospitals are improving value and affordability for their patients and communities. These hospitals have implemented strategies that improve outcomes, enhance the patient experience, and lower cost. Today, I'm talking with leaders from CHI Health's Creighton University Medical Center. From the Department of Family Medicine, we have Dr. Amy McGaha, a physician and chair of the department, Dr. Kristy Keefner, a physical therapist and assistant clinical professor, and Dr. Tom Gluck, psychologist and vice chair of the department, as well as the director of behavioral health. This diverse team of healthcare professionals has joined me to discuss their experience implementing team-based care and show how this approach improves value for their patients. And I'm so glad that you're all able to join me today. Let's get started. So I think to start things off, it would be helpful to get some background on CHI Health and Creighton University Medical Center. Can you share a bit about your hospital and the community you serve?
Hi, Julia. This is Amy. I am a family physician working in Omaha, and I first came to Creighton University prior to the merging between Creighton University and CHI Health Center. That actually happened a couple of years after I had joined the department. The initial partnership was with Allegiant Health, and then that transformed a couple of years afterwards to CHI Health. But really, we've been in this partnership between the university and the health sciences schools with the university and CHI Health for about 8 years. CHI Health is a clinically integrated network that goes from western Nebraska to some hospitals and clinics in western Iowa also. So it's a pretty large health system that covers both urban and suburban and rural locations.
So when you started your team-based care work, what problem were you trying to address, and how did you know it was a problem?
This is Tom. Just to follow up on what Amy was saying, as a result of the merger or the partnership, I guess you would call it, between CHI and Creighton, one of the outcomes of that coming together was that they were going to close the old Creighton Hospital, which is more toward the center part of the city of Omaha, and move the School of Medicine's clinical rotations and some of the residency programs about 8 miles west of downtown. But because of Creighton and CHI's mission to serve our inner city population, they did not want to abandon this area of the city. And so they committed to building a facility near the Creighton campus that would be really the house for not only a clinical enterprise, particularly based on primary care, but also would be a learning laboratory for the health sciences schools that would be across the street at Creighton University. So this would be a place where students could actually get clinical experience. We then started the process of developing a team that would look at what that would look like, everything from how the building was built, what's the architecture, what do we really need, all the way to how do we develop a team and what are the services and the academic ventures that we're going to do in the building, what do they look like. That all started probably back in about 2015 or so. We eventually opened the door to the new facility in January 2017.
That's great that you were able to build it with such intention from start to finish. So I know that there are many models for team-based care. And so can you talk about the model that you implemented in your organization and how you got there?
what really started to come together in 2016 was several different teams who had been working together in parallel or in different locations, kind of independent from each other, then agreeing to come together and move forward. From my perspective, in the Department of Family Medicine, where our family medicine residency training program and our family medicine faculty practices included both inpatient and outpatient medicine. And of course, with primary care, you're talking about frontline initial presentation of patients and the closest intersection with the community. And so we had already undergone a process to implement the principles of the patient-centered medical home within our ambulatory practice. And so we had received NCQA certification prior to that. We had built little different elements of the team. We had some piece of integrated behavioral health. We had a significant piece of pharmacy. We have a school of pharmacy, and so we had pharmacy integration. But we didn't really have, we had a nurse care coordinator who had been put in the clinic as part of our cooperation with our accountable care organization. But we really hadn't become systematic about it until we went on that journey to get NCQA certification. And that really just gave us a framework, an operational framework for moving forward. So then when it came time to move the practices, so it was the family medicine residency practice, and it was the family medicine faculty practice, and it was the OBGYN women's health practice, and cardiology, the cardiology ambulatory practice. When all those things started to move to this location here in downtown Omaha, we brought with it already this existing culture of principles committed to patient-centered medical home, and at that point in time, the triple aim. We really hit the quadruple aim a little bit later, and we can talk about that without necessarily intending to, but we were very deliberate about looking at value, looking at patient experience, and looking at quality, and that's kind of how this team came together. At the same time, our clinical partner, CHI Health and CHI Health Clinic, the clinic part that manages the ambulatory piece, we're really starting to look at how are we going to participate with value-based care, which sites are going to be our CPC plus sites. And so we were kind of at the forefront of the mind for that conversation. So that's where kind of the basic primary care bundle came to be nested in this location. Then there are lots of other important pieces, including physical therapy. So then we were able to expand and have physical therapy, and we have physical therapists who are committed to education. We were able to expand and have diabetic education and have all these pieces that are actually doing this within the framework of the educational site.
And I'll piggyback on that as well. This is Kristy, Brandon Keefner. So we also have, in addition to physical therapy, our occupational therapists, and we've just added speech therapy. And I'd say it's more rare to have the rehab services integrated into the family practice PCMH model in the way that we've done it at this time. So we've had organizational support at the leadership level. And we also have, I think we've brought together the people who want to be in this level, who want to integrate into this primary care practice. So we attend huddles twice a day. We've got a provider from OT, occupational therapy, and physical therapy that will attend the care coordination meetings that we also host. And so we're able to really participate in that from the clinical side as well as in our outpatient clinic, which is just a little bit separate, but our providers are able to come down and introduce their patients to us. We can get the provider's perspective outside of what we're reading in the electronic health record. And truly it creates that relational care that I think has been integral in teaming. And I think if we look at what has made this work so well, in the beginning, we had the opportunity to really get to know each other. And it took down this barrier that was not only physical through our walls, we were able to talk outside of the computer and see each other face to face. And we're able to go up into the provider's rooms as well as they come down to ours to evaluate or screen a patient or answer a question if either one of us have concerns or just want to double check something that we may have a question on. And so previously, I think we thought we knew what each other did, but on a regular basis. We're almost 4 years into this. We're continuing to learn from and with each other the more we work together.
This is Tom Gluck. I would like to just add a couple of other things to what Kristy and Amy have already mentioned about models of team-based care. We were really quite intentional when we came to opening the building in January of 2017 about developing the culture that we wanted in the building. And we spent about a week just working on training, getting staff to know each other. We really based some of our work on the work of Eduardo Salas, who has done a lot of work. He's from Rice University and has done a lot of work on teaming in a lot of different varieties, including healthcare. And so we really paid a lot of attention to what kind of culture do we want to have, one that has a lot of psychological safety for staff members, everyone from the front desk to the people who room patients, to the service providers, and anybody who would do any kind of follow-up work. We wanted everybody to be involved in that. And so we were quite intentional about developing the culture, and I think that has really paid dividends for us down the road. We still think that is really valuable and something that we pay close attention to. And so as a result of that, we do have a kind of a culture workshop at least once a year where we just kind of go back over and review things. We came out of our culture development with a couple of sayings that I think have been really helpful for us. And one of those is, we're all teachers and we're all learners. And so no matter how high your degree is, you can also be a learner. But and if you're a front desk person, you can do a lot of teaching as well, which is helpful in establishing the culture that we want. And the other was that we had a saying that it's called assume positive intent. And so whenever there's conflict, and we recognize that conflict is going to happen, and that's normal, and that we embrace it, we engage in it, we don't avoid it, but we also assume that what the other person is saying is coming from a good place, and that when we assume positive intent on their part, that then allows us to work through any conflicts that we have.
I love that you brought that up, Tom. This is Kristy, because we have to keep saying that. We started that in the very beginning, but we have to keep saying it for ourselves as well as our learners and our other providers, because it helps to keep everybody in a good mental state, a good framework for why we do what we do, to assume positive intent every day, that we are all here for the care of our patient, and that everyone is a teacher and everyone is a learner. And we have to intentionally name that for our learners so they continue to feel that psychological safety when they come here, because I don't think it's typical. We've got an interesting and a great culture here. One more thing I might add from the academic perspective, I would say the Center for Interprofessional Practice Education and Research really helped to bridge and to help us give a framework of what they used for building this, and that would be the interprofessional core competencies and the triple aim, which we now refer to more of the quadruple aim, and then the interprofessional learning continuum, as well as the discussion of the nexus, bringing together the education and practice realms and putting out the research, which Tom will talk more about later on. But if our readers wanted to look up those frames and those references, I would say that is something academically that we look at. But day to day, I don't know that we really think about that in total. We do our work and it comes together as a team.
You have to get the culture right, though, and you have to set the culture and reset the culture and continue to refresh the culture, because I think that people have great ideas and great projects that they can develop, but if you actually want it to sustain and to continue to regenerate and grow, and then also what we've seen through COVID, what happens when the complete foundation of the work that you're doing is hit? If you don't have that culture right, it's all going to fall apart. And so I do think that so many times we get very focused on, what are our quality metrics going to be, and how are we going to participate with our ACO, and what are our hospital readmission numbers and those kinds of things. And you think about that first without getting the culture right. And so I do think that that's been a real key to how we've been able to get as far as we've gotten and continue to move forward. The other piece to that, too, talking about everybody teaches and everybody learns, I think that for those locations that are academic health centers, recognizing that when you have a new generation every single year of graduates who are leaving and new residents or fellows or students who are coming in, that gives you a chance to continue to refresh your culture if you do it right. And it's so much easier to sell to a new learner, this is the way we're going to do this, as opposed to somebody who's been in practice for 20 years. Sometimes making that change is so painful and disruptive. But with new learners, as long as you continue to be attentive to the culture, that can really be a facilitating factor.
Yeah.
Just to elaborate a little bit on the COVID example that Amy mentioned, I think it was because of our culture and the ability to be flexible in our thinking. We were able to be up and running with telehealth in response to COVID in a matter of days. We didn't struggle with it at all. We had frustrations and we had mechanical failures and we had all kinds of problems that we had to solve, but people really worked together and everybody pulled in the same direction.
And another piece about our clinic is we have a very large percentage of our patients are refugees who have resettled from Myanmar. They're Burmese, Karen refugees, Bhutanese who have settled from Nepal. And so we're doing this in a situation where we have patients with very significant interpretation needs, being able to just communicate with our patients. And then also we are right at the forefront of what was going on with the meatpacking and being able to kind of see what was going on with meatpacking with our refugees who are working in that location. So this is real rubber meets the road kind of work, not just the abstract.
Yeah, absolutely. And I love that you all keep bringing up the culture piece, because I think when we hear about hospitals who are trying to form interdisciplinary care teams, the culture piece is really a struggle for them. So I'm particularly interested in what it takes to build that culture, and also how that's enabled you to evolve your team-based care approach during COVID, and just would be really interested to hear some stories of what that looks like now.
I think one of the things that's important to recognize about the model of care that we put in place with, Kristy alluded to it earlier about the interprofessional education and collaborative care practice model, is that we had champions emerge who decided that they really wanted to do this, both from the academic side and from the clinical side. I think what happens is you have to identify some of these champions who really are committed to doing this and who take responsibility for carrying the culture forward and implementing it and keeping it alive. Then the next task then is, once those champions have come on, is how do you replace a champion if they move on, or how do you develop processes that are sustainable? I think that's still probably one of the transitions that we're experiencing. We're about 4 or 5 years into this now, and so we've had some people who are obviously very talented and have opportunities to go elsewhere, and we're still working on how to make those transitions and make them sustainable.
Right, and I would say, so this is Kristy, when we were forming this building, our leadership told us what this was going to look like, since I'm primarily a clinician first. And to me, it was, this is what I want to be a part of. This is going to be something really special that I want to be a part of. So I would say my colleagues came to this team in the same way, wanting to practice interprofessionally with the primary care team. It's a great place to work, and I would never look back.
I want to just give you an example of a patient care that where teamwork was involved. I'm a psychologist, and I do a lot of work with patients who have chronic pain. Dr. McGaha has patients who have chronic pain, and she has often asked me to come in and talk with one or more of her patients. And I quickly recognized that this person also needs physical therapy. And so Kristy and I and Amy become a somewhat of a little teamlet that's working together to help a patient cope with their chronic pain and to regain function. And so when Kristy is seeing the patient in physical therapy, it's not uncommon at all for me to have my psychological interventions right there in physical therapy. So the patient is doing, let's say, 10 reps of some sort of exercise. They get to 5 and they want to stop. And so I will refresh for them the idea that their pain is not an indication of harm, but that it does hurt, but they're not doing any physical tissue damage. And so that gives them permission then to continue on. So we can reinforce the strategies and the ideas that we want to have right in the same environment. And so from an interdisciplinary perspective, it really helps the patient get the same message from all providers.
to give this context, whenever I talk to colleagues in other locations, people are doing a lot of the same things that we're doing, but what they're not necessarily doing is they're not naming and framing it. And so you may have a physical therapist who is a great colleague and you partner with this person for any patients with chronic pain. But if you haven't specifically identified this as part of your team or cohort, you're not really maximizing your opportunity. So I think that's a big part of being able to say, Tom is on my team, Kristy is on my team. Particularly when you look at the patients who have the biggest struggles, it's chronic pain and coincident mental illness. And so there's no way that within just the traditional medical model that we can meet those needs. So for chronic pain and for coincident mental illness, being able to have integrated behavioral health or physical therapy is essential. The other piece to that, and to go back to your question about what have we learned or how has this been successful, I've had to change some of the ways that I practice or the ways that I think about things. And if you don't have that from the leadership, and particularly from the physicians, as much as we want to talk about teamwork, we all recognize that if the physicians aren't on board and really leading this, it's really going to be an uphill battle. But one quick example, as a family physician, I look at the family unit as being able to help me know what's going on. So those families where I take care of both spouses and a kid and maybe a grandparent, I have a lot more context to what's going on in the relationship and what might be going on with the family. I have one family that I actually care for 4 generations of this family, and that relationship has helped me care for this family. Well, 2 of the patients I felt like needed to see a behavioral therapist. I did not recognize that for my behavioral therapist colleague, she had a conflict of interest that she is not really supposed to take care of 2 different people from the same family. And so when you talk about professional scope and rules and regulations within different professions, I think I have this assumption that we all operate under the same ethics and guidelines, but that's not really true. So I had to figure out a way that the behavioral therapist and I could kind of work together to best meet the patient's need. So it's just, you have to be willing to be open and change. The other big piece that I really learned and come to value from this is that despite all of our best efforts and all of our resource attention, there are some patients who are just going to struggle to meet the goals that we've all set out together. And that actually it's my relationship with my colleagues that we help each other. Because there's often a lot of feelings of guilt or failure myself that, Bill has ended up in the emergency room again, or Bill has had another exacerbation of his illness, and it's a failure. But to be able to have that team together really supports each other in a different way.
Absolutely. And there are so many important threads there to pick up on. But I think that always learning from each other, and also how you noted that the traditional medical model just can't help solve all of the problems that we see in our health system. So really exciting to see these different groups coming together to try to figure out a new way forward. So I want to shift a little bit to the impact of this work. I know that you've been doing some research and studying the value of it. So can you talk about that a bit, particularly in terms of the impact on patient outcomes, on the experience and cost of care?
Yeah, this is Tom. I've been doing this kind of work for quite some time in terms of looking at what kinds of impact do medical or psychological interventions have on patients, both in terms of their function and their satisfaction and those kinds of things. So I thought this was coming together to form this nexus was a real opportunity for us to set up a research design. And so what I was able to do was to go back to the clinics that were operating prior to our move into the new building, and I got data for a year within our CHI system on how many patients, or I got the names of patients who had 3 or more ER visits, 3 or more hospitalizations in a year, a hemoglobin A1C above 9, and then we also wanted to look at patient charges within our system. And so I got data on all of those patients for 2016, the year prior to our move in. Then we put the model in place starting in January 2017, and at the end of 2017, I compared the 2 years, and what we found was we reduced ER visits, hospitalizations, and A1 significantly, and had a profound impact on the patient charges. So we published that paper in the Annals of Family Medicine in 2019. And the most recent project we've had is we wanted to see if those changes are sustainable. And so I took the same cohort where we got the original changes from 2016 to 2017, and I've looked at data now in 2017, or 2018 rather, in 2019, that same cohort, and what we found is that those positive changes have been sustained. And we also then looked at two other patient cohorts, and they also made the same kinds of changes. So we have what we call sustainability and replication of the findings, and that paper has just been sent out for review. So we'll wait to see when or if that gets published.
That's fantastic. Congratulations.
Thank you.
I'll piggyback on Tom as well. So our team came together and recently published a paper in the Journal of Interprofessional Care, and our readers can find it. It's titled Creation of a Primary Care Academic Collaborative Nexus, Enabling and Interfering Factors. And so really you can read the story of how we came together and some of our findings throughout this process.
Amy alluded to the idea that triple aim and quadruple aim. The study that we published last year really looked at triple aim issues, but we've also kind of had some anecdotal data on the quadruple aim, and that is the care of providers, if you will. In the year 2016, before we got together, the clinics that merged into our facility here had staff engagement scores that were probably in the lower third of the CHI system. And the year later, after we've been involved in the program, that score was now in the upper tier. I think we were in the ranked 1 or 2, somewhere in that neighborhood in terms of the CHI system. So just staff engagement and satisfaction improved significantly as well.
We were number 2, but I always have to put the qualifier that apparently the clinic that's number 1 only has 3 staff members. So, so considering that we have a few dozen people who work in this clinic. And the other piece that was really remarkable was, I don't think that, in fact, I'm quite confident that the staff did not want to make this change. The clinical staff did not want to make this change. The front desk staff, they were very comfortable in their previous clinics. And so having 2 sets of front desk staff, 2 sets of clinical staff come together was pretty disruptive. But again, going back to the culture, I mean, we're talking really basic things. We went to the art museum one day and everybody created joint art projects with a newly defined team. At COVID, during our huddles, we would have somebody lead us in a few yoga moves and exercises. We're talking really basic things to continue to affirm how important the rest of the team is.
I think the early training during onboarding, which we've also done again, is the conflict resolution training from a student perspective, from a clinician perspective, and even our providers who have been here. That was really helpful to bring everybody together and talk about how do you overcome differences? How do you overcome struggles, and seeing those obstacles as an opportunity rather than as a negative, and helping us to harness that energy to become better and to keep moving forward rather than becoming stuck. It was really helpful.
Absolutely. These are all hugely important things for building culture. So as we start to wrap up, we always love to share with our listeners and our readers some insights to what you've learned over the course of implementing team-based care that they could take into their own work. And I know we've talked about this some, but any other thoughts?
I guess one of the things that I'm a little bit concerned about is I'm the senior citizen on our team, so I've kind of gone through this a couple of different times. I've done work with patients who have chronic pain, and we discovered that interdisciplinary pain programs have good efficacy. I worry a little bit that if healthcare reform does not get put in place and that the financial incentives are not such that support this kind of model, this may go by the wayside. We think this model will thrive in a value-based care reimbursement system. But what's interesting about it is we found these outcomes in a predominantly fee-for-service model. So we know it works even in a fee-for-service model, but I think even once you get the financial incentives in the same place where everybody is benefiting from the same reinforcement systems, I think that assures that this model will work even more effectively.
I was just going to say, I think it's important to define and redefine every year roles and responsibilities. We've done what we call spotlighting every July when our new residents and fellows come in, and that's been helpful to discuss, particularly with my profession of physical therapy, what we do. In a way, we are redefining and rebranding that we are the movement specialists, so our providers can discuss with their patients. I want you to work with Kristy, or I want you to work with Morgan, my colleague, and they are really the movement specialists. And I understand that you're having a difficult time getting up and down from the floor. Well, they're going to really figure out what the barrier to doing that and help you be able to do that a little bit easier. And when we talk to our providers about what we can do and how we can help the patient psychologically, physically, that has been really helpful. I think also bringing the right people to the table, people who want to work collaboratively, has been really helpful as well.
For me, this has been so much fun to see how my own personal practice of medicine has changed, and to be able to show for the next generation of students and residents who are learning in this clinic, to show them kind of what the future is. We do try to deconstruct for them to say, you might go to a clinic when you graduate. You might end up in a system, in a hospital system, where this is not in place, and we want to teach you how to build this. You may not have a Dr. Keefner, you may not have a Dr. Gluck. Here's how you can kind of help put this together. This is what it looks like. So that's been very rewarding. I do want to go back and echo what Tom said about the need for administrative and policy support and payment alignment. It's really no secret that a lot of this work has become enabled because I and Dr. Gluck and many of our faculty are supported by academic dollars. And so we're doing this as part of our educational endeavor. And our time allocation is this is part of my educational endeavor. And so it is a challenge to figure out how to actually value this in different models. And we see that the patient satisfaction is improved. We see that the quality is improved. We see significant savings in the patient charges, but we have to be able to figure out how to really encourage and enable this to be done in any model.
Absolutely. I think that'll be one of the great challenges for our field going forward, but an absolutely essential one. So just to wrap things up, what's next for CHI and Creighton in the world of team-based care?
Well, one of the directions I want to take a look at from a research perspective is we've looked pretty closely at the outcomes, but I want to focus a little bit more on what are the processes that get those outcomes. So what are we doing? What are the components that seem to have some real salience in terms of getting the outcomes that we want? That's one piece I'd like to look at. And then in terms of the nexus where we have academics as well as the collaborative care, I want to maybe focus a little bit on student outcomes as well, to take a look at how are we doing in terms of teaching these models to the next generation of healthcare providers.
I'll echo what Tom says. I think that we know that the interprofessional model is helpful, especially for our patients with chronic low back pain, but really parsing out why it is effective and what is the secret sauce per se with these patients would be helpful.
Another area I think our system is wanting to look at is our building is co-located with a freestanding emergency department, and looking at ways to really improve those patients who continue to come into the emergency department without a usual source of care, without primary care. I think we've done a good job with just the adjacency that we've been able to get some improvement, but we really, like Tom said, we don't necessarily have strict policies and processes that are in place for how we can help facilitate that for patients. Even things like, and our system has been very supportive at looking at things like copays. So if a patient goes upstairs to the ambulatory clinic and they're going to collect a copay before the patient is seen, what do we do to keep them upstairs in the ambulatory setting and not just go downstairs to the emergency department where there's no copay? And our system has been very supportive at looking at ways to try to help alleviate that. The financial support, the social determinants of health. We haven't even talked about our work with food insecurity and transportation issues and helping our patients get enrolled in ESL classes. Like, there are a million things that we are doing and that we need to do more with social determinants of health.
No, I was just going to ask about with social determinants, or how you're screening for social needs, or what you're doing in that space.
So with social determinants, this is still a process in evolution. I think your question about how do we screen is really, really important. I think a lot of times our screening is incidental or happenstance, that in asking another question, I happen to find out that you have food insecurity. Actually, this happened with me yesterday with one of my longstanding patients, that she admitted to me yesterday for the first time that she runs out of food before the end of the month. And so I don't think that we're screening for that and capturing that information as effectively as we can. I think one of the opportunities there is to put that in the hands of the patients so that it's not something that's asked within the medical visit by the nurse or the physician, but rather that the patient can kind of self-identify what their resources and needs are so that we can refer them. I have to acknowledge that CHI has developed a pretty impressive program called Community Link. And Community Link is a grant-funded program that's embedded in the different clinics. And they are professionals who strictly really just help link patients to existing services. So I wasn't doing a very good job of advising on bus routes. I got fired from that job. So having somebody who really can give information about this is the bus routes, here's where you can go to the Social Security office, heating and cooling assistance, this is who you call and where you call. We're finding those because of just the nature of what we do, but there are definitely opportunities to be more systematic about asking questions to patients. Do you struggle with literacy? Are you interested in classes to help English as a second language?
Yeah, once again, the value of interprofessional care teams so that you don't have to know the bus routes, but you can work with someone who does.
Right.
Kristy, you were chiming in there?
Yeah, I'm smiling and nodding right now because we had a patient the other week that was referred for musculoskeletal pain. A patient who has diabetes, and we were talking about what are their barriers to addressing their diabetes and getting their blood sugars under control, what are their barriers to movement and exercise, and what came out was a food security issue and feeling safe in their home. And the ability to be in this nest of other providers, I felt confident and confident to be able to go back to our primary care provider and say, hey, thank you so much for sitting down to physical therapy, but we've got these other barriers that are primary and some mental health issues that are primary that we need to go back and address. It was having those networks to be able to get that care as soon as possible for the patient that I think will ultimately help them be successful in meeting their goals.
A huge one that is coming up shortly for us in Nebraska is that we are going online with Medicaid eligibility. So that starts October 1st. So many of our patients who are eligible for Medicaid will now, we have the Community Link program who can help them with some of the paperwork and show them where they need to go and those kinds of things. So getting insurance for people obviously helps their options in terms of their health care.
Absolutely. Well, Amy, Tom, and Kristy, I want to thank you all so much for joining me today. We certainly look forward to hearing how your work continues to grow and evolve. And if you all figure out that special sauce for what makes interprofessional care work, we really hope that you come back and share that with us. So this has truly been an excellent example of how hospitals can improve value for their patients and communities through interprofessional care teams. In the world of the Value Initiative, for more podcasts and resources to promote value in your community, you can visit our website at www.aha.org/The Value Initiative. Thank you for listening, and please join us in the future for more Members in Action podcasts.